Good morning, everybody. It's a bright, sunny morning here in Cochin, and I welcome all the delegates, students, faculty, everybody to the second day of this international conference, SASH 2021. Just to quickly recap before we start today's proceedings, we had a very interesting day yesterday with luminaries lined up for speaking on different topics of interest in the healthcare industry. We started the day with an informative session by Dr. J.L. Meena sir, Deputy Director at the National Digital Health Mission. He took us through the corridors of the Prime Minister's Jan Arogya Yojana and how the digital platform will enable us in seamlessly improving the continuity of care to the people of the country. The second session was deliberated by Dr. Sandeep Reddy, our international collaborator from the Deakin University, who is an expert in digital health, and told us the scope of how the digital health is improving day by day, and which will be that will enable us to seamlessly connect with the healthcare community. The third session was deliberated by Sarabani Basu, our healthcare consultant and experts, who helped us to understand the intricacies between the healthcare workforce and the digital interface. We had an interesting session by Mohammad Zafar Ali on how entrepreneurship is proving to be a key industry innovative ideas that is coming up and helping us to explore this scenario. We also had a very interesting session by Alexander Thomas, President of HPI and founder of Kaho, who also deliberated the challenges that we are seeing increasingly going up in the healthcare industry. I forgot to mention the very interesting session by Dr. Harish Pillai, COO of the Metro Pacific Holdings in Philippines. It was a very informative session of how the challenges are being addressed by the healthcare providers and the industry in actually seamlessly integrating the process of digital mapping in the healthcare industry. The post-noon session, we had informative sessions by Professor Venkat Ramaiah from the Indian Institute of Management, Lucknow. He gave us a huge window of opening into the materials management challenges and the digital integration. This was again followed by a panel discussion on technology and impact of healthcare delivery by Dr. Ajay Bakshi, who moved on to be the CEO of Neurance AI Technologies. The day was winded up with a scintillating quiz for the students with 3 joint winners. The PR prizes are ready and it will be delivered today. So that brings us to the start of the second day. We are extremely delighted to have Jake Nicholson, Principal Consultant at Stanford Center of Innovation. He is talking to us on impact of digital health and technology in healthcare delivery systems. The session will be chaired by Professor Hem Chandra sir.
Very good morning to all.
Professor Hem is a distinguished luminary in the field of hospital administration. He has been heading the SGPGI for a long time as medical superintendent and is presently the Vice Chancellor of HNB University. We are extremely delighted and thankful to you, sir, for joining us this morning. We are all aware that how busy you are with the convocation scheduled for tomorrow, but you took time to be with us this morning. We are really thankful to you, sir. May I request Professor D.K. Vijay Kumar, sir, Professor of Surgical Oncology, who will be the co-chair for this session. Just to give you a prelude, we had been in good association with Stanford for the last many years on many projects. The recent one that we did was on quality improvement with Jake Nicholson, and in surgical oncology, how we could improve the quality of oncocare. May I request Professor Hemchandra to invite Jake Nicholson and introduce him to the delegates and members here today. Thank you very much, sir. Over to you.
Thank you very much, sir. Thank you. A very good morning to all of you, ladies and gentlemen. First of all, we both, myself, Dr. Hemchandra, and the Professor D.K. Vijay Kumar, will extend our heartiest gratitude and the thankful to the Amrita Institute of the Medical Sciences and the Academy of Hospital Administration for inviting us in this annual event of the SASH-2021. And we are highly delighted to be here, though I could not personally attend this particular event due to my busy schedule in my forthcoming convocation tomorrow, 2021. And otherwise, I would have been there personally. And in fact, we intended to be there to meet all of you for the first time in the Kochi. And today's topic is very, very important in impact of the digital health and the technology in healthcare delivery system. In fact, as of now, we are facing to each other due to this digital system. And today, as Dr. Saab has already introduced a little bit, the renowned speaker from the US, that is Mr. Jack Nicholson. I warmly welcome Mr. Nicholson on behalf of the Academy Hospital Administration and the Amrita Institute. And nice to meet you for the first time here. And we have heard a lot about you. A little bit more about yourself. Mr. Jack Nicholson, is the principal consultant at the Center for the Innovation in the Global Health Stanford University. He is an expert in healthcare improvement practitioner and has coached various clinical project teams working in enhancing the clinical effectiveness and the healthcare access across the globe. He has developed various training programs that continue to serve the major institutions in the US, India, and the Cape. So a little bit, this is only a few part of his delightful introduction, and I warmly welcome you on behalf of this SASH organized by both the renowned organization. Welcome, Mr. Jack Nicholson. I now invite you to kindly take the charge of your dice and start your dedication. Thank you very much for coming to us. Please.
And thank you. Thank you for that kind introduction. It is so great to be with you all. I was in Kochi 3 years ago and visiting, enjoying the food, enjoying the coast, and enjoying many of the people there. And then I did have the opportunity to visit Assam 2 years ago, right before COVID. And I love to go to India, and I hope we can return to that new normal at some point. But I'm happy to be with you via Zoom. I hope you can hear me okay. Am I coming through okay?
Yeah.
Okay. Excellent. Well, I'm going to go ahead and share my screen and go through a few of the lessons we've learned at Stanford University and with some of the institutions in India. I'll touch on that at the very end, about the impact of digital health and technology in healthcare delivery. This is a very present topic, and when I saw that this conference was focusing in this area, it excited me to see that we're looking for change. We're looking to embrace some of these new innovations that have come out there. I want to start my talk today by telling you about a personal experience that involved a plant called poison oak. Poison oak is a common poisonous plant in the western United States. And if you get in contact with it, you'll find out 2 or 3 days later. It leaves an oil on your skin that causes an allergic reaction, and it is very painful. It stays with you for weeks. It doesn't go away. And it's also known as poison ivy, poison oak. There's a lot of different terms for it. Back in 2017, these are my parents, I took them on a bike ride, a mountain bike ride. And my mother, who's pictured here, she fell off her bike on the side of the trail and landed in some poison oak. We didn't know the extent of it, but a few days later, she had this allergic reaction all over her body, and we needed to treat it. And so we ended up having to go to an urgent care center to get some steroids and some anti-itch cream, to help treat it so that it would go away over the next few weeks. Then in 2020, I had a personal experience with poison oak. So this is me with some of my children, and we were out hiking near the coastline in California. And look, I'm wearing my mask, so I was trying to be good. And lo and behold, when I got back from this hike a few days later, my whole face was swollen because it was covered with poison oak. Somehow one of my kids had my mask, dropped it in the bushes, and then I put it back on my face. And this is what I look like. So it looks like I just went through a fight. But no, that was just the reaction of poison oak all over my face. And I share you these two experiences because it leads me to something that I learned through both of them. When I got poison oak on my face, I did not have to go to urgent care. I did a quick video visit and was able to get the drugs I needed, the steroid I needed. And it was interesting when I compare and contrast what my mom went through and what I went through with poison oak. In fact, I wrote it out. So if we look at what my mother went through, she got poison oak, and we had to take her to an urgent care center. It was a 40-minute drive to the care center and a 40-minute drive back. We spent 2 hours at urgent care, and the doctor prescribed a common steroid treatment called prednisone. That's what's used for poison oak. It took 24 hours from onset of symptoms to receiving the drug. That's how long it ended up taking. And then we were charged, of course. We had a cost charge for visiting the urgent care center. That's what happened in 2017. And then you look in 2020, when I got poison oak, I had a video visit on my phone with the on-call doctor, and I talked to that doctor from my bedroom. I sat on my bed, showed him a picture of my face on my phone. I just had my phone like this. And I said, here, look, I got poison oak all over my face. It was a 3-minute video call. He prescribed the treatment prednisone. I got it within 1 hour of onset of symptoms, and I was charged 1/10 of the cost. Same scenario. Both needed to treat poison oak, but very different processes. And a lot of these, in the 2020 process, a lot of it was pushed because of COVID, because of the pandemic. These idea to do video visits, make it quick, make it easy, not have to go to a facility. And man, was my care so much better and so much more timely. So this leads me to my first major lesson when it comes to digital health and technology. And I'm going to go over 4 major lessons in this talk, 4 things that I've seen over the past few years, witnessed at Stanford and witnessed at other organizations. Digital health opens doors for less costly, more timely patient care delivery. Let me show you an example. We have been learning a lot at Stanford about e-consults, electronic consultations, especially in the psychiatry setting. Psychiatry demand is higher than ever right now. And what I mean by psychiatry, I mean mental health or behavioral health needs. And we have been striving to adopt electronic consults, or what I'm going to call e-consults, in a very holistic way. What is an e-consult? It's simply a physician-to-physician written electronic consult. It's asynchronous. So if you're a primary care provider and you want to hear from a specialist in psychiatry, you have a patient with a mental health need, you want to hear from a specialist in psychiatry, you can ask for an e-consult. Something you type in or send them an email, and they, when they have the time, will respond to it. They don't meet with the patient, they just respond to it digitally and send the primary care provider a consultation. That referring primary care provider has a great learning experience. They learn more about psychiatry and may be able to respond to the patient's concern without having to refer them to psychiatry. That's what an e-consult does. And so the way it works on a process flow is that PCP, or that primary care provider, instead of going through that traditional route where I send a referral to a specialist, they can say, well, you know what, I just have a question. I just saw my patient. I'm not sure if I need to refer him or not. I just have a quick question. Send an e-consult, and that specialist can provide a quick consultation to the PCP. Well, this is what we've learned as we've done it at Stanford. So in 2020, in September 2020, we had Dr. Zane pictured here. She became the go-to psychiatrist for e-consults for primary care doctors. And they would go to her with the following needs. An e-consult. They just had a question. She would do a quick chart review and provide a consultation that she could send to the primary care provider so that they can provide it to their patient. They also provided MD to MD urgent advice. If the primary care provider had a patient in their room and they were thinking, do I need to send this patient to the emergency room? I'm not sure. They could call Dr. Zane and get a quick advice on that. And then when needed, Dr. Zane would provide co-visits with primary care providers. And this is where she would meet with the primary care provider in the room with the patient or on the video and do a co-visit. But those didn't happen very often. In fact, these two, MD to MD and co-visits, are very, very rare. The e-consults was the majority of her role. And in doing this, this is what we learned. So take a look at these charts, and I'm going to try to walk you through them. So we tested Dr. Zane's role as a specialist providing consultations in 4 clinics, 4 primary care clinics. And the number of referrals to psychiatry dropped 13%. So primary care providers started to refer to psychiatry less now that they had Dr. Zane there to provide consultations. And, of course, e-consults went up. So, see, we weren't doing any e-consults before, and we started averaging about 30 e-consults a month, these 4 clinics. So we thought, well, is this just chance that referral volume has dropped? Is that just chance? So we compared it to some control clinics. And we found that the control clinics, referrals to psychiatry were going up. So these were clinics that did not have e-consults, did not have access to someone to do this for them. And they were increasing quite rapidly due to the pandemic, due to COVID. Referrals to psychiatry were growing quite quickly. While these clinics were dropping, even during a pandemic, the referrals to psychiatry were dropping. And so what we learned here is that psychiatry e-consults are more timely and less costly than a specialist referral. The psychiatry referral, so to go see a psychiatrist, it was over a 30-day wait. To get an e-consult, they would get it back between 1 to 3 days on average. And it was 1% of the charge to the patient's health plan. So now someone may ask, well, does an e-consult resolve the patient need and concern? Was that good enough? Well, we studied 90 patients who received a psychiatry e-consult. Only 11 requested a visit with a psychiatrist after their e-consult. And we looked at within 12 months. So that was a long time frame. We took 90 patients over 12 months. After they get an e-consult, only 11 ended up visiting with a psychiatrist. So I had an 88% resolution rate. So less costly, more timely, and they're resolving patients' concerns. And the way that it works now, and this is now being spread across multiple areas at Stanford, instead of going the traditional referral route where a patient sees their primary care provider, is referred to a specialist, and then waits to get to visit with them in an office visit, they now can do an e-consult where 85% of them are getting resolved without an office visit, and only this 15% or so have to go see a provider. So that's one of our lessons. The second one I talked to you about is that to ensure ongoing healthcare quality, we must be deliberate about appropriate use for digital health. And this is important. In our dermatology department, we put together a team to understand when is it the right time to use digital health, especially for dermatology. Let's try it here first, and then maybe we can share learnings with others. So the target was to perform an analysis to derive a target band for digital health and a consensus on appropriate use criteria. When can we use a phone visit, a video visit, or when does it need to be in person? And let's start with dermatology. Well, in doing it, this is what we learned. We learned there's about a 3-step process that any department should consider when going down this path. 1, first, understand your care delivery options. What can you do in your department or your institution? You can do in-person visits. Maybe you're doing procedures. Can you do phone visits? Can you do video visits? Can you do e-consults? Do an inventory. What is the type of care that we can deliver in our institution? Then, once you do that, create a conceptual model. How do these options work together? So if you found that these are the 5 you have, how do they work together? This is what we did. So we did a conceptual model in dermatology, and this is what we learned. We learned that as patients come through this funnel of meeting their needs, a lot of them can be solved by an e-consult. Many of them, an electronic consultation. But some come through there, and I know this is kind of busy, but follow me here. But as the patients come through, some may need a video visit. Or some will get an e-consult and go straight to a procedure. Some may go from an e-consult and go to an in-person visit. And then maybe after a video visit, it goes to in-person, and then it goes to a procedure. But there's different models that we have to think about and be deliberate about when we set up how we're going to deliver care using digital health. And then after the procedure, if there is a procedure performed, maybe there is a phone visit as a follow-up. It doesn't always need to be an in-person visit to follow up. Maybe a phone visit would suffice. And as you come up with this conceptual model and you're thinking about how I'm using digital health, set some rules, set some standards. For example, one may be that for new patient referrals, let's try to do it as an e-consult first. Maybe that's a new standard you're going to try. Or maybe this is your standard. All patients not meeting in-person criteria should be seen via video, period. Something to consider. And then maybe here on the bottom, established patients who already are seeing this doctor often, how do they fit in this? What does this conceptual model look for your institution? This is a good exercise. And as we work into digital health, we need to start thinking about these models. The third step, after we have a model that we're thinking about, we've got to define what is clinical appropriateness criteria for in-person versus virtual encounters with patients. And this is just a conceptual model here, but you may come up with something like this. Patients should be seen in person when any of the following criteria are met. And maybe you do it by your ICD-10 codes or the codes for the different exams or procedures you do. Or maybe it's a visit type, or maybe it's if it's a biopsy or a skin graft, laser treatment. This was just a model for dermatology. But having this, once you have a model that you're thinking about in your head, or that you've put down on paper, you can now go into these criteria and agree upon as colleagues, as a department, a clinic, or an institution, that here's some criteria we're going to start using to support our model. And then the fourth step is identify measures to track adherence to and effectiveness of the model. So maybe you choose a measure like patient satisfaction. As we try this model, we're going to measure how satisfied patients are with their continuity of care. Or maybe percent of patient records complete with lab imaging and other diagnostics. This is something that our dermatology department had to work into pretty quickly. This idea that, okay, if we're going to use video visits, we better have their labs already, the information from their imaging. If we don't, it's going to be hard for us to be able to really help these patients. So looking into things like that may be a good measure. This is another measure we're using, patient and provider ability to understand needs during virtual visit. We ask providers this and we ask patients this. Maybe an interesting measure for you to consider. Or adherence to the model. This is a 4-step process that, as you think about incorporating digital health, it's one that you can go through with. The third major lesson I wanted to review with you is that digital health puts us farther from the patient, which means we must be closer to their data. This is something I just touched on with the dermatology example. Some measures we're currently considering, now that we're learning from the pandemic and starting to embrace digital health more, we're looking at things like what percentage of e-consults end up in a resolution? How many are converted? What is the average turnaround time for an e-consult? How long does it take to do an e-consult? Those are some of the things we're looking at. You may also look at what's the average days from someone getting an e-consult to going to an appointment when that does happen. You may also look at social equity. So this bar chart is showing the percent of females who come in person versus phone versus video, and then males. And you could also do this by race or ethnicity. We'll make sure that these virtual offerings or these digital offerings are offered in a way that does come across equitable for your different patient populations. And this is another interesting measure to consider. ED visits within 7 days. Do patients go to the ED much more frequent if they started with a video visit or a phone visit or an in-person? That's another thing we should be considering as we embrace digital health. But before we set targets, we must explore. I get a little scared about using these new measures and people saying, well, let's set a target. This is new ground. This is stuff we haven't really understood yet. So there's going to take some time in the healthcare. It's going to take some time in the healthcare setting to watch measures such as these, and think about, all right, what is optimal? What should be the target and benchmark? But we need to hold on setting those until we watch these for a while. We're doing that at our institution as well. The last lesson I want to share with you is just that now that the impact of digital health and technology is we can now collaborate and learn from each other more than ever. And this is an important lesson. Some of you may have participated with the group called Equip India. Equip India, standing for Enable Quality Improved Patient Care, is a team of providers who come together where we can learn and apply evidence-based quality improvement science to improve patient care in India. And how do we do it? How do we learn and collaborate? Using digital platforms, using things like Zoom, YouTube, and online learning. And I've now watched Equip India do this for 4 years now, and the impact has been very notable. It's been remarkable. Using digital platforms, the way we can collaborate and cross time zones and countries has been so powerful. Let me just show you an example. In our first year, Equip India collaborated across 7 different institutions: AIMS, Tata Memorial Center, MNJ, Pipla, Omi Baba, Thrissur, and Trivandrum to work on things like decreasing days to referral, increasing home visits, the capacity to do home visits. And they were able to do this over YouTube, Zoom, online learning platforms. And now after 4 years, Equip India has touched 22 healthcare teams, 60 plus physicians and staff, and 11 different states in India using digital health platforms, digital technology that is now coming into healthcare and becoming part of what we do. And it's showing results. In the Indian Journal of Palliative Care, the April-June issue, the first 8 publications in this issue were projects coming out of Equip India, highlighting things like protocols, prognostication documentation, referrals to palliative care. There's been a number of different things, and to see it being published and shared with others is something that I think is really neat that Equip India has been able to show. And it goes, I need to show some of the faces here that make it happen. But one who's really made it happen is Nandini Valath, Dr. Nandini Valath out of Tata Memorial, who's been the director in pushing this forward. So again, I'm going to end on this. We've got 4 major lessons that I wanted to share with you. That was a brief summary of them. When we think about digital health and technology, it can be less costly and still safe and more timely. We must be deliberate about how we use it. Think about those conceptual models. It does put us farther from the patient, so we must be closer to their data, but we can now collaborate and learn from each other more than ever before. I'll close with this quote by Albert Einstein. What's the definition of insanity? Doing the same thing over and over again, expecting different results. Digital health allows us to do something different and get better results. So thank you, everyone. That's my presentation.
Thank you very much for nice deliberation, Mr. Jack Nicholson. We are extremely happy to go through your all the deliberations, especially with the collaboration with the Indian medical institutions. And as of now, absolutely, we are very correct that the digital health system is the #1 requirement, especially we have observed during the COVID-19 era for during the last 2 years. And this remains the only tool to join us either from any part of the globe or the country or the state. So I can invite now the questions from the audience or the participant or our learned other speakers also in any question. This is a nice opportunity that Mr. Jag is with us today. And thereafter, I will request my co-chair, Dr. Vijay Kumar, to proceed further and sum up the total deliberation given by the Mr. Jag. Any questions, prompts, or any query or any feedback or the information to be sought from the Mr. Jag? It's a nice opportunity, learned participant or the delegates. Do not lose the great opportunity.
Professor Hemchandra, please, may I be permitted to ask something?
Sure.
Dr. Surekha Kashyap here from Pune.
Yeah, Surekha, yes.
Yeah, Mr. Michelson, I'm an ex-army doctor, speaking to you from Pune, Maharashtra, near Mumbai. I'm just keen to understand whether some ethical or legal framework or guidelines have been formulated to cover this kind of delivery of mental health.
Yeah. You know what? It's hard for me to speak to that from the Indian perspective, but from the United States perspective, the legal guidelines have not been an issue. The same legal guidelines that apply for an in-person visit apply here, and it's for like an e-consult. I'm guessing what you're asking about from what we learned from psychiatry, and so if there are legal issues, it's handled as it would anywhere else. It's not introducing anything different from that standpoint.
Okay, it's not covered in e-health record or e-medical records guidelines or IT guidelines for healthcare.
There's not anything, yeah. So there are some guidelines that maybe I could send you if it would be helpful for you to read through them. And And if you want to connect with me via email, I could send you some documents, but not something that I'd be able to word and talk through here in this meeting. But it's a great question. Yeah.
Thank you. Thank you.
Yeah.
Any more suggestion? Any more question from
Dr. Nicholson, this is Dr. Prem Nair from Amrita.
Hi.
Hi. I was just wondering, yesterday we talked quite a bit about digital divide, the generational divide, the economic divide. Do you have similar problems in the United States with ethnic populations or the American Indian population?
Yeah. We have, that's where I think it's important that as we adopt digital care delivery, we have measures in place to show if it's coming across inequitable because of some of the digital divide. And I don't want, like I said before, I don't think we should set targets here because there's much still to be understood. What we've seen in the United States, in some areas actually, in more rural areas, the digital platforms are less costly, they're more welcoming. Because almost wherever we go now, people have a phone. They may not have a computer, they may not even have a car, but they have a phone and access to an internet. And so for a place like Stanford, an academic medical center offering tertiary care, these rural areas can get access to a specialist without having traveling to the hospital. And that's a major win. But I'm not saying it's totally solved. I think it's something we need to be careful with and establish measures for, so that nothing we're doing becomes more inequitable as we adopt more digital health.
Yes.
Okay, Dr. Hemchandra, can I ask a question?
Sure.
Jake, I wanted to ask, I'm Dr. Ashish Gupta. I want to ask what type of technology platform do you suggest for e-consult in our country, and especially keeping the confidentiality of the patient information in view of that?
Yeah.
Open platform or something which is dedicated, closed type of platform?
We've integrated into our electronic medical record. That's how it's part of the record, the notes. How would I explain this best? I know this is maybe hard to translate into the different, the way the institutions work there. But a primary care provider will put notes in the electronic medical record, no matter what it is, that will go to the specialist who can review the patient's chart. And using apps, phone apps that we can have on our devices that are PHI protected, so patient health information protected, patients can access the notes from that specialist using apps on their phones. So for example, for my health plan, I have an app that I can see notes from my doctor. If there was an e-consult, I can see those notes. I can see the dictation from a CT scan I may have received. And so the world is coming out with more and more apps that people can install on their devices and still keep things confidential. But that's an institution level action to adopt these apps and make it part of their care. It's changing faster than I can keep up with it. Sometimes I talk to someone younger than me and they have an app. I'm like, oh, I didn't even know that was available. I'm still catching up.
Is there any other questions or comments?
Jake, can I quickly ask you this? See, the referrals are coming down. That's what is clearly shown in your slides. How does it impact the financial sustainability or revenue sustainability of hospitals?
Yeah, I'm so glad you asked that. Because if someone is going to adopt e-consults, you're saying you're willing to be risky. You're willing to say, I'm going to take less money because I'm going to do something that brings in less money into my institution. But in the end, I feel like it's the right thing to do. And so what we have found, and it's been interesting to watch, is that yes, the referrals go down because of these e-consults, But but in areas where demand is already high, that gap is eaten up by patients who need to see a specialist, who are currently waiting 30 days. And now that we have e-consults, maybe they only have to wait 20, or maybe they only have to wait 10. So the backlog of patients waiting can go down and still fill up the hospital capacity. But it all depends on demand. If you're at an institution where you don't have much of a backlog and you start doing e-consults, yeah, you might start seeing you have empty rooms. And that is a financial discussion with the leaders of the institution. It really is. And there is an institution in Utah, one of the states in the United States, who actually showed on their financials that they did lose money in being willing to take this risk. But in the end, they're still doing okay. They've been able to maintain the profit and move forward. But I'm glad you brought that up, because that's a discussion that should be had, because the incentives don't always match up. As a surgeon, we may be incentivized to do as many procedures as possible, or as a psychiatrist to see as many patients as possible. So you have to kind of look at the incentives and say, how do we change the incentive to where the surgeon still wants to do procedures, but it still is financially okay with them to do an e-consult? For Dr. Zane, the one I mentioned, we had to change the way she was compensated to where some of her compensation was based on just time, and some of it was based on surgery volume or psychiatry volume. And instead of all of her compensation being on volume. So those are conversations we have to have and figure out. So, but it is a risk. It's an absolute risk.
Thank you, Jake. That was wonderful. Actually, this is Dr. Vijay Kumar here. I have been a participant in the EQUIP workshop. We met at Assam. Me and Dinesh were there, and I can vouch for the fact, most of you students at least who are sitting here, the clarity of thought, the way which Jake presents things, it makes it so much more easier to understand. To look at a problem in a holistic way and to try to reach solutions. It's an evolving field. Digital health is so much of an evolving field. And I always feel that we have to be thankful to the COVID pandemic, because that's one thing which has accelerated our movement into the digital field. In India, it's been tremendous. The movement across the digital health transformation has happened very rapidly because of the COVID. And this is something which, if you look at the plus point, of COVID as a disease, though it does cause a lot of negatives, but it's something which is there to stay now, and we have to realize the impact, and therefore it's very important that we start looking at guidelines, looking at new ways of formulating our policy, looking at ways of integrating our traditional care with the digital health, because India has got so much of urban-rural divide in many places. There is so much of other practical difficulties in delivering healthcare that the digital way seems to be one of the ways with which we can really go forward and impact significantly the healthcare delivery in India. So I was very impressed by Jake's presentation. Jake, thanks a lot. You've always been crystal clear.
Well, I tried, and I thought there's so much to cover. You could talk about artificial intelligence, you can talk about machine learning, but I hope to give you a few nuggets that you can walk away with.
That's true.
Walk away with and try some of these things. It's scary, but it's exciting.
Yep, very true. So I think with that, we shall
So
close.
there's a question
Yes,
from
please.
one of our audience, from Dr. J.N. Rao. Can you suggest proper digital health or technology for rural India?
So I just wrote in the chat. So no, I can't, unfortunately. I don't have something I would suggest for you because I don't understand your systems as well as I'd hoped. But there is huge power in being iterative in trying things. And try it for a week. Try it for a few hours even. And see if there's ways to work around certain things. And I think when we adopt digital health solutions, it's not going to be transformational. It's going to be iterative. Meaning, and if we take that iterative approach and are willing just to test and try and learn, I think we're going to gain more ground than purchasing something huge and putting it in place. So that's just my advice on that.
Thank you, Jay.
Thank you so much, sir. On behalf of SASH 2021, we would like to present a memento as a token of gratitude to our speaker, Mr. Jake Nicholson. Also, we would like to present a memento to our chair, Professor Dr. Hemchandra.
Thank you very much. Thank you. Thank you very much.
Thank you very much, everyone. Much appreciated.
Thank you, Jay.
Now, may I request Dr. Prem Nair to present the memento to our chair, Mr. D.K. Vijay Kumar. As we move on to digital health, security system and protocols are the most challenging factor. We have amongst us Mrs. Samvedna ma'am, who is the architect of the cyber security with IBM. On behalf of SASH 2021, we invite Ms. Samvedna ma'am to deliver her talk on cyber security in hospital and healthcare operations. We welcome you, ma'am. Now I request Colonel Sureka Kashyap and Dr. Ashish Gupta to chair the session.
Good morning, everyone, and welcome, Mr. Samvedna. This is the first time that we are meeting, and that too virtually, thanks to all the platforms like Zoom and Google. Distances have become meaningless. So good to meet you. Hello, I'm based at Pune. This is an important topic precisely because of the explosion in the use of digital platforms for healthcare delivery. Earlier, it was just telemedicine. We had some telemedicine rules, and the government was quick to revise those rules in March of 2020, the moment COVID struck. However, when we say that the world has become a global village and distances have become shorter, the distances are shorter for the virus also to travel. And the virus can be COVID as well as the virus which destroys the software on which our e-health records or e-medical records are based. So it will be very interesting to hear from you. Looking forward to your talk, ma'am.
Welcome, Mrs. Savedna. I think we are going to have a very exciting session. Good morning, Colonel Sureka. We are here. So please carry on with your presentation.
Namaste Shivaya. What an unusual way to start Sunday morning, right? I've got something for you. What do you see here? Plain glass, right? Okay, I have one more item here. What do you see this? And I will request the organizers to arrange a prize for the right guess, please. Do you know what it contains? Quickly guess on Zoom, chat. Let me help you here.
Same glass.
This also contains same glass. What is the difference here? Difference is that this glass here is carefully kept protected. This one is not. And this is the challenge, to find the right container where we can protect the data. This is the data in this case we are talking. So do I need to go with talk still, or we can wrap up? Thank you very much, AIMS and AHA, for the opportunity. Let me share some of the information that I would like to take you to. Okay, my slides are up. All good? Let's get started. So, thank you very much for the warm welcome. I work as a security architect with IBM. As part of today's session, so I'll start with overview of information security in the context of healthcare sector. Next, I will share some of the details about cyber attack we have seen on healthcare industry in past, specifically in last couple of years. We then take a look at some of the risk associated with this IT-enabled environment and how to mitigate them, to ensure the smooth operations. Then we will take a look at some of the key objectives when we try to have smooth digitization of healthcare, what should be our key objective to ensure, that things are working in a smooth manner? We will then take a look at some of the building blocks that should be considered for the sustainable growth. Finally, I will share some of the recommendation, from the vast list we have to protect and secure patient data. Let's get started here with some interesting thing. And thank you, Zach, for the previous presentation where you actually laid down the foundation for mine with digital healthcare services, right? So digital healthcare services have paved the way for easier and more accessible treatment. And I don't want to emphasize much, it has been already shared. However, the present day healthcare industry also become the main victim of both external as well as internal attacks. Though the data breaches are of different types, their impact is almost always the same. The data from the healthcare is regarded as very highly valuable. And this has become a major attraction for the hackers and increase of security concern. So let us start with some overview of information security. As you're aware, variety of hostile, intrusive software actors, which includes, as ma'am told just now, virus, worms. I know I'm using a lot of medical terms here, but they are in terms of IT. Trojans, we have ransomware, we have spyware, adware, scareware. So, the list is exhaustive. And other intentionally malicious program that aims to disrupt the CIA triad of information security, which is confidentiality, integrity, and availability. And together, these three principles form cornerstone of any organization's security infrastructure. So confidentiality is what? It is a means to ensure that only with appropriate rights are able to access the information. Integrity is about ensuring that information is not tampered or altered with any other unwanted things. Availability is ensuring that information is available when required in timely fashion. So we all agree that the CIA triad, this three function should work as a goal of every security program in healthcare industry. There are other industry where one of them is sufficient, but healthcare is the only one where all three has to work together. And we do this by focusing on multiple data processing activity. The data, the gold mine that this industry has, which is like collection of data. As with digital health shared in the earlier presentation, you have amount of data available now in digital form. You are storing them in your infrastructure. You are disclosing them, and at the appropriate time, you are transferring it from one device to another, one mobile device to another mobile device. You have to dispose them, and they are like both in electronic and they also are in paper form, right? So it is essential to maintain the protection and integrity of and availability of individual personal information that the hospital has, and our organization confidential information also all the time. And we have legal, we have contractual, and we have ethical obligation to respect both privacy and confidentiality related to individual information. Now let us examine these three important principal dimensions in the context of healthcare information. Let's assume that the data in question here is patient health record, which could include obviously the sensitive medical data. It also can have personal identifiable information, that is called PII, and as there will be financial transaction for billing purpose. You also may have credit card information. So the rising use of mobile computing, the growing build your own device culture. We are moving with our laptop in our workplace. We are moving with our iPad and other mobile devices. This all culture is increasing, and it is increasing the likelihood that this data will be breached. An attack against this medical information integrity could be unfortunately life-threatening. So, I can, think of a more benign attack. It might, try to aim to alter someone's address to reroute his or her formal correspondence. But what happens when we know the threat actors that we discussed just now, the virus, the Trojans, malware, they try to change a patient's drug dosage. They try to change the prescription or, simple in the report, the blood type itself. Such breach, as you can imagine more than me, can be catastrophic. Okay, so before, we move to the next one, I mean, this is like, some of the example of happened in the past about the cyber attack. And I'm sure we have Dr. Dinesh present in the audience, and he will have more example in his mind, but that we will keep it with you today. But for today, I just want to have a couple of examples here. And we all agree, we understand the violation of data privacy rights or law can have serious consequences. Companies violating data privacy rights or law may face consequences, such as loss of business, loss of trust, the most important thing, the reputational damage, and it can also result into large financial loss. If I will give you example of EU region, that's what I have. EU region has a GDPR compliance requirement, and that requires all data which, if it has to go out of EU, that is not at all possible. It has to remain in EU region. There are 5-6 countries as part of EU region, and the penalty for that is 4% of companies' annual revenue worldwide, or $20 million. So, such financial losses are associated. There are legal costs, there are fines, the list is endless. So, several threat monitoring tools, IBM also has like X-Force, and there are so many other tools available. They do online monitoring of observe such campaigns. And what they do is, what they have found is that these threat actors run spam campaigns, and that impersonate to be from, originate from a legitimate companies. For example, WHO, they will look like, I'm from WHO and I need some information on an urgent basis kind of thing. Some in form of, malicious email, and it will continuously send. It will not stop at one point, and it will look like, if somebody is really looking for information, and that will spoof the application to open some attachment. And that will in turn, it will trigger a malware infection in the device. And that it results into, cyber criminals to collect sensitive information, and sometimes even take control of the device in which that attachment has been opened. So since last year, when WHO declared outbreak of COVID-19 pandemic, several threat intelligence sharing platforms have found that there is a 6,000% increase in spam related to, it can vary from the topic that everybody wants to know about COVID-19. It can be related to anything. And such spams have increased. That is a huge number. Ransomware attack, it's a major cyber security concern for all industry, believe me. But attack against healthcare has a huge impact because of the potential consequences of patient care. You can imagine if a retailer, or I go to a supermarket, if that is compromised by ransomware, what will happen? As a customer, I'll go to somewhere else to get my product. But in case of hospital, that is not really an option, right? So that's why it is this ransomware attacks are targeting hospitals, and it has become a lucrative business for criminal ransomware operations. And the nature of healthcare requirements are constant access to system. That means in many cases, the victim, and in which case it will be hospital, they will give and pay the ransom demand for the decryption key. So ransomware attack against hospital have very direct consequence to patient care. There are examples where in past it has reduced the availability of systems. It can reduce the availability of the medical operation services. And because the whole network has been encrypted, for which the key is with the attackers. So, according to the survey done by the anonymous company in the healthcare organization, ransomware attacks have resulted in something like patient being kept in hospital for longer days. There will be delay in test. There are delays in procedures, and most disturbing, sometimes it results into some kind of fatal issues as well. On the next category, related to phishing attack, this is related to a spear phishing campaign, which will target, it has targeted in past the medical supplier with COVID-19 theme emails, and these frauds will be, they will involve that I belong to health and medical related product, and I have, done research and services, and that will appear from, the legitimate source. And actually, they are not, they will not be. So with some example, let us move to the next one, the interesting topic. Before that, I would like one thing, to do, just take out your mobiles. And for me, tell me how many of you have at least shared your password, at least you have shared it once. Or think about, don't tell me, I have people in this audience that who do not have password in mobile. I don't want to hear that. So, that kind of risk we are going to talk about now. Most of the, diagnostic intervention, that is used by the medical industry, it involves radiology, you have pathology. They are all these days enabled by digital technology, right? And keeping that in mind, and in addition to that, we have all medical related operation, administration, everything is like digital based. So let us closely look at some of the very common type of cyber attack risk. So ransomware, I'm sorry I repeat this, but this is like theme of all risk and attacks seen from past year. So in this case, what happens is crypto malware is designed to render information available through the process of encryption. So ransomware attack is a direct attempt to quickly monetize the inherent value of, the information that is held by the hospital. Unfortunately, ransomware is here to stay, and they are becoming more profitable, with the time. I will tell you one example, like these days on cloud, there are services running. There are a lot of useful services, there are a lot of useful apps, but ransomware as a service is also operating, and that continue to lower the barriers for entry for, the more cyber criminals to launch the attack. Insider threat. So this is the situation where threat, an employee or a contractor will use his or her authorized access knowingly or unknowingly to do harm to the security of the organization. Weak and shared password. Compromised password are one of the most concerning risks for hospital and healthcare services. So in this, over 80% of data breaches are due to compromised password in some capacity. When we talk, about in survey or any, data gathering stages, so clinical staff often follow the path of least resistance when it comes to the password, and they often have, opt for password that will be simple to type, easy to remember, and this includes password something like the name of the hospital itself with, putting some common simple substitution. Unfortunately, cyber criminals are aware of all these typical substitution patterns, so they are very risky habit. 73% of surveyed hospital staff had obtained the password of another medical staff member, and there are numerous reasons, and believe me, they are all valid, as they will sound valid as well, why a healthcare staff will share the credential. The most cited reason that we get is that every minute count in critical care. However, like weak password, password reuse or sharing the password decreases the efficacy of password altogether, creating the vulnerabilities. About the vulnerable devices now, the next item. So healthcare organizations are greater risk than other sector due to the complexity of network that is involved in the usage of such devices. There are range of devices, range of IoT devices are coming up in healthcare delivery organizations. The breadth of manufacturers and its types, and the reason that always on use of many devices within a hospital or healthcare environment has led to an increased security exposure for many. So 75% of healthcare organizations are affected by TCP/IP vulnerability alone, because these devices has to communicate right with each other. So the most common vulnerable device which I can think of will be like infusion pumps. It can be patient monitors, or it can be any point of care diagnostic systems. All of them have to talk to each other. So that's how it creates the spectrum of attack. Phishing attack, this is related to the phishing emails that we talked about. They will spoof to appear from an very legitimate organization, such as everybody wants to know what is WHO announcing these days about new variant and something else. So it will talk about very common information that as a common person anybody would like to know about. Last year everybody wanted to know when is COVID-19 vaccine coming out, who all are getting into that, reaching the stage where it can be released for the a common person. So a lot of such information. So such things are gathered and they will be sent as an legitimate emails. Unencrypted data. So it's a major vulnerability when it comes to healthcare data breaches, and it could result in very direct impact like greater fine in the healthcare industry. It involves something like stealing of unencrypted USB device. It can be unencrypted laptop, or they can cause severe damage to the industry. So the next one is about the unauthorized gain. Unauthorized gain to patient medical records occur. When it will happen? When individual who lacks the authorization, the permission, or any legal authority accesses the data, and which can include even protected health information, and which is inside your patient medical records. So this actually includes all type of attacks that can lead to exposure of this confidential data with the help of internal source in the organization itself. The last one which I would like to talk about is related to misleading URLs. This is like really something which I suppose you can map it to your experience. You might have heard from your relatives or some of your patients. So what happens is, it is said that it is best to assess the source of medical information available today in the internet with open mind, because they might be inaccurate. Misleading medical information meaning it can be any post, it can be article, or any shared resource which can misclaim the current medical knowledge. It can range from a fake news article or post that will talk about something simply which is not true at all. It can be simple as sending a fake URL to to your patient in email, or it can post an article that which will not contain true information, or it will not be accurate, it will not be up to date at all. So internet is full of such example, to have such thing. As a medical practitioner, many of you might have come across situation where patients come to you with information such as folks from internet, I have seen that they have claimed that they have cured their diseases with some natural remedies, or they will talk about some self medication, self prescription, something like that. There are many such legitimate looking health focused sites that peddle all these false misleading claims to large audience. And you also might have come across people who will search their symptoms or diseases online, and their search actually they will get lot of, they will come across well sourced health information also on site. And these sites actually to add their credibility, they will add reference to multiple peer reviews as well. It will look like it has done study, and whenever any inspection is done, all credibility will vanish. So such things are part of the misleading URL. After looking at the risk that we have here, Let us now get into something, the mitigation, some of the ways that we can think about handling them. And these are like some list from the many of the available options. For the ransomware, many guidelines urge healthcare security professionals to ensure that your system should be patched both at the operating system level and application level to handle malware, right? This sounds like a great advice, but in reality, some machines cannot be patched. Either they are running mission critical application, or it can have software incompatibility. In such cases, the complementary or compensating controls are available. And such as you can have separated dedicated network access to such system. You can have enhanced intrusion detection system. You can have enhanced intrusion prevention system, IPS capabilities. So, so that the threat to the CIE of the information that is held is protected. Intrusion detection system is nothing, but it will analyze the network traffic for the signature that will match to the known cyber attack. Intrusion prevention system is something which will analyze the packet, but it can also stop the packet being delivered, based on what kind of attack it is trying to do, help to stop the attack. So for the next item related to insider threat mitigation, we are moving to increasingly towards some security model, which is never trust, always verify approach. This is also known as zero trust security model. In order to protect network and devices against this expanding, cyber threat landscape, this is one of the approach that can help to hold the most sensitive type of data in the network itself. So, the zero trust networks can actually help strengthen hospitals to cybersecurity both inside and outside of the network. So the key objective is achieve a state where every transaction being conducted by an entity has an authority to do it. This process is making sure that both inside and outside of the network are being held accountable for what they are doing to get better control of the network. So this approach, zero trust approach, actually helps that you are validating the behavior of endpoint, reducing the risk for the endpoint itself. To the endpoint, it is going to talk to some other endpoint. So like that, you do not trust anything. You do not trust the network unless you do not trust the machine, unless the machine has been identified or authenticated. You do not trust the application unless it is authenticated. You do not trust the database unless the transaction is being properly authorized. So it goes in, for the weak and shared password. We employees often will have seemingly very good reason for sharing password. Password sharing make it easier for multiple user to access team account, leaving a password on a sticky note under keyboard. That allows a worker to log in on a business account on an emergency basis when the colleague is out of office. However, sharing the password can make be more vulnerable in getting the accounts hacked. For example, despite of all the firewall you have installed on your computer, if a coworker logs in with your credential on his or her unprotected PC, hackers can get the information easily that they are looking for. But there are ways to achieve different way of authentication. That will be something like certificate based password, certificate based authentication. Okay, so now related to vulnerable devices, we have so many devices within a network that can be a real nightmare to manage and keep track of all of them. I'm telling you, this is not possible manually. Obviously, there are tools available to do that. There can be misconfiguration in them. There can be default settings. Consider the most risky things because all the default settings are available on internet. Default password of the any shipped device. Inherent vulnerabilities make it too likely that these endpoints will be exploited as a means to attack a network. So because we have IoT medical devices that has to share information with so many other endpoints, that is the whole purpose, and they can be very powerful vector for the damage. So here what we have to remember is that the goal is to deliver an effective patient care, and it is therefore critical that security professional, they engage with the clinical professional, the IT security professional, they engage. And the reason is that some of the some of you as a medical professional, you have worked in for decades, and you do not need a tool or software to diagnose disease at the first stage. You know it because you can recognize by talking to people, by understanding their the behavior, symptom, and all of them. And that is why we call you a human whisperer. So IT security personnel need to talk, understand the workflow, the devices which are in use before implementing any heavy-handed security approach, no matter how secure it will sound on the paper. For the phishing attack, as a mitigation, we have to minimize the amount of information which is available. We have to train workforce for cyber incidents. We have to filter out all suspicious content. And we can think about deploying multi-factor authentication instead of having just password authentication for the systems. The last one related to unencrypted data mitigation. So from a security standpoint, encryption is essential to keep patients' data protected. The PHI is safe, right? Health data encryption occurs when data is converted into encoded format, which is unreadable text. Unless a human has to read it, only machine will continue to read that, and it will be inaccessible without a decryption key. So this encryption will help protect PHI when it is transmitted, when it is stored, when this data is in motion, when it has to travel from one point to another, when it is at rest in your hospital server or any mobile device or laptop. So we should consider all these data encryption options as we move towards implementing new devices, for new ways of storage, including cloud. Okay, the last one, I think also I missed the unauthorized gain. So, it is too often that threat is inside organization and they have gained to, the data in an unauthorized way for this sensitive data. So the most obvious prevention will be here to make sure every employee understand both the definition of privacy and sensitivity of the data, and access control, device control, password, and all of them can help with that. For the misleading URLs, the only possible mitigation that I can think of is let us direct people to go to the right place for the information that they are seeking for. Let them go to hospital, the doctor's office, any authorized community center, telephones like nurse on call or direct line to doctor, pharmacist. Let all their query get resolved. And I suppose the last session where we talked about such e-consulting will be really helpful here, because you are directly talking to reliable health information place. You're not going around, the website and a lot of things. Let them direct to a medical journal. So that's what I can think of here. So as in summary, healthcare organization, we all agree we need a holistic enterprise approach to address the risk for CIA of the sensitive information. It is critical to build security strategy that balance the risk, and we have to embrace the disruptive health technology, such as a lot of medical devices are coming out, and with these capabilities we can enhance patient experience. And there are a lot of things that are added, but they also pose the entry point for the malware, and these did not exist decades in the past. Okay, so let us move on to some of the key objectives, because now we have to define the key objective, because we have to provide protection to patient health data that it deserves, solution that we can live every day. So this information here is in paper, it is in electronic form, you have prescriptive narratives, you have labels on prescription drugs, and any location where it can be observed by an unauthorized individual. So we also need to think about retention, how long we have to keep this data active before it will retire. And additionally, we need to consider about not only local law, like, there was a question about rural India, and we know that there are some well-established countries have the laws in place. So we have to think about local law, but we also need to think about international law, like other country, other nation state, so that we have covered the spectrum of requirement completely and properly. Let us start with something like security and privacy by design model, where data is considered to be protected from the time of conception of the design. Collect only when it is necessary. Share only if it is needed. Avoid, any data breaches. Prevent careless disclosures. Think about having dedicated cybersecurity department if not already present. We have to take small step. I'm reiterating from the fact it was discussed, because we have to identify problem, we have to identify weakness, strength, and always have ways for human to stop the process this machine is trying to do, because that is where we need to improve. Okay, so we discussed like a lot of strategies here. So one thing that I want to emphasize and really want to emphasize is about healthcare sector is not an IT sector. It is enabled by IT. So once we understand the risks and ways to prevent them, we need to get into delivering a sustainable capability. And what I mean by that is healthcare organization is not some sector where we can just go and start a security service, because it is a service in itself that is treating patients day in and day out. So the change that we would like to bring in may not be implementable immediately. How much ever R&D we do, we come up with this data analysis and mining and all of them, but we have to talk, we need to create, basically we need to create a strategy, enhancement roadmap, and keep visiting them so that we can see, we can revise, and we can take a look at what are we doing. We have to deliver the transformation in stages, and then we look at every stage to identify what is working, what is not working, what are the improvement that we need to bring in, what need to stop doing, very importantly. So keep benchmarking, along the journey to see the improvement. And one of the thing I really want to mention, and I really mean it, is it is about changing mindset for tomorrow. And for that, innovation is required. So we need to have innovation factory, because we cannot predict the future accurately. So there is no book of standard implementing security for medical sector. Do this, tick, tick, tick. Nothing like that. So constraints are not at all clear, and there is infinite degree of freedom. So in this case, we have to do prototypes, we have to do proof of concepts, experiments, and it is a very challenging industry to work, but it has a lot of opportunities. Okay, so we discussed a lot of strategies here, in the last about half an hour. But immediate thing is what? We have to improve the governance model. We have to improve process. We have to introduce new ways for security operations, increase the capability of threat response. We have to test our resilient plan. It is now we know a threat, we accept it. Now we work towards mitigating them in some kind of continuous improvement model. And this will surely take healthcare for a strong, resilient, security system. So I want to emphasize that security is not a product, it's a process that we have to live through. So much information about security can make us feel little insecure, but that's okay. That's how we have to solve the problem. So we have to do right things, but we have to do at the right time. And as in healthcare organizations, this industry is, investing in latest technology advancements, sometimes obviously for better patient care, sometimes for cost saving. Cyber security measure must be considered. Healthcare data encryption, de-identification are two essential methods to ensure that PHI security is maintained. So that's all I had to share today. I hope it was helpful, and really innovative things are happening in this area with the launch of digital medical IT as part of Ayushman Bharat. Let us arm ourselves with, we have to win this battle of cyber threat as well. Thank you, AIMS and AHA, for the opportunity.
Thank you, Savedna ji, for an excellent presentation. I will set the ball rolling by asking you a very simple question. In healthcare, where accessibility, timeliness of accessibility of information of a fast changing scenario in a patient who is being cared for in an intensive care setup, where decision points, decision related information is quickly to be accessed, putting up roadblocks for cyber security itself looks to be counterproductive and at variance with this objective. How will you achieve that?
So thank you very much for the wonderful question and the icebreaker question. Yes, many times we see, cyber security as the additional thing getting added to the process, and I agree to that. But we also need to think about the future, the impact. If we do not take care of these things today, what will happen in past? So there is a lot of work going on with respect to improvement that can help to address such, it does not add any time, it does not add any additional resource. It may add cost, but eventually you will know that it was worth. So a lot of things are happening, a lot of innovative things are happening day in, day out. There is a research, and I would like to share that even IBM has a dedicated research department for medical industry alone, where doctors and IT professionals work together to address the concern that we would like to address, on the timely manner. But we need to talk more. We need to talk more about it, and I would be glad to talk to you, offline, sir.
If I may, in the armed forces, we have a laid down system of having independent cyber security audit checks done every quarterly. Would you recommend that for a private setup as well?
Yes, madam. Yeah, that is really very much important, and that helps you to actually understand both the local law and where are you dealing. And as you say, right, respect local and be global types, and that also will give you it's not only important, it is mandatory as well, because these things keeps revising. I'll give you one example. In one of the region, we have compliance to meet, then there will be 10 items that you have, the 10 checklists that we have to follow. Next time it will become 11, or it may become 9. So we have not seen becoming 9. So it has to be up to date, which is very important. And you have to keep track of the things, and that helps, such regular audits surely helps to achieve that.
Okay, I think the topic is open to questions. Any question from the audience or from the internet? Sir, anybody? So, Surekha, you want to add something further to this, or I should conclude? Colonel Surekha, you want to add something?
Just, if you permit, there are just 2-3 things which I would like to flag, since this is such an important and well-attended conference. There are 3 regulations, guidelines, or acts in our country which will be known to all future and present hospital administrators. I'm sure the seniors already are aware. One is the IT Act 2000, which defines the sensitive personal information and personal information, which cannot be shared by the hospital without the consent of the patient, even if it is in digital form. Second are the EHR standards laid down by the Ministry of Health and Family Welfare in 2016. And administrators must have a copy of it. They give in great detail about the standards which are required for hardware, for software, for data sharing, and they have defined data ownership. The data ownership remains with the patient. And the most challenging thing about electronic health records in India, and I'm sure worldwide, is the fact that the ownership is with the patient and the hospital is the custodian. So the data is owned by the patient and the hardware and the system is owned by the hospital. So legally, it is a very, very thin edge on which the administrators have to walk. Maybe it is time for all hospital planners to actually formally plan an IT department within the medical record section or within the telemedicine department of the hospital. And lastly, the telemedicine guidelines have been released in March 2020. So it will be good for hospital administrators to be aware of the legal framework, at least, under which digital health is governed in our country. Thank you.
For the benefit of the students, because there are a large number of students, I may recap what is the take-home message of this program. The CI triad of confidentiality, integrity, and availability must always be kept in mind. The threat is inside the organization. Weak password is the most common cause of that threat. So look at that aspect. That is very important. Then goal is, try to understand what is our final goal. Final goal is efficient, effective patient care. So the medical person should be a part of the cybersecurity team, and the initial design is being prepared, because the initial design should be adapted as per the security, and we should prevent any unauthorized access to the data. Any last word from Samvedana for our audience here? Over to you, ma'am.
Yeah, I would like to, say that let us consider cybersecurity risk as patient risk itself, and you give us utmost importance. And I would love to talk to you offline. Please feel to reach out on LinkedIn. Om Namah Shivaya.
Thank you.
Ma'am, there's a question.
Yes, please go ahead.
Do you think India has resources to establish a self-reliant data storage industry where we can save data, particularly healthcare data of its citizens? How private and public industry come together to do that? It is said that the nation which has stronger data protection systems can be winner in the coming decades. And it is interconnected world. This is something becomes difficult to not involve international company, particularly countries which are in competition with India.
Very, very valid point here. And I would like to share, on behalf of IBM, but we have there is a two type of model which works in the cloud, when it comes to data protection. You have public cloud where, obviously the hospitals are not much going there because of the less of privacy available. But there is a hybrid model in which what happens is some of the information, as ma'am also emphasized, that the patient data remains with you, right? And it is protected. It is in your hand. So when what to take action. And there are some information which goes in the public side. So that hybrid approach is being very much getting popular. And I suppose this has been this is an area which is getting very much attraction and innovation. Things are happening because people would like to get into that mode instead of having a high cost solution where you have all the data in your private network as a private cloud, or go think nothing about security and move it to public cloud. So there is a lot of information about it. And if you can post me that question, I can share you the links where we can find the details there. But there is, it is available, and it can be utilized also.
What is the most ideal technique or tool to prevent cyber attack on patients' data in healthcare industry?
Okay, so yeah, I mean, this is something which is very close to my heart, because I ensure as my day-to-day work activity, I actually analyze the threats that is reported for my product, and there are series of tools available. There are threat monitoring tools like IBM X-Force. There are other tools which can help you with the known cyber threats for the products that is deployed in your organization. We also have a mechanism by which, if there is a cyber security cell installed or present in any organization, so what happens is there are third-party ethical hackers. They report to you directly instead of going to internet, just to disclose whatever they find out. So there are, tools in place which gives the information at right time, and actually they give us also timeline to fix it before it goes to public. So all these things are, taken care, and those there are tools, that information also I can share, which can be helpful.
Okay. There are no further questions. So I, on behalf of the organizers of SASH-21 and Academy of Hospital Administration, I thank you, Mr. Venaji, for very crisp and eye-opener, presentation on cybersecurity. This session is declared closed. Please proceed.
Thank you, ma'am. Thank you very much for this informative section. I hope all of you had enjoyed the session. Now, on behalf of SASH-2021, we would like to present memento as token of our appreciation to our speaker, Mrs. Samvedna ma'am. And also to our chair, Colonel Sureka Kashyap. Now I request Dr. Yashpal Sharma to present the memento to Dr. Ashish Gupta on behalf of SASH-2021.
Moving on to our next session, marking the glorious moment for the whole medical fraternity, Dr. Ravi Kanan, renowned oncosurgeon of Kachar Cancer Care Hospital, received Padma Shri Award for his exceptional work on cancer care to impoverished communities of Assam, Meghalaya, Manipur and Tripura, which was conferred to him on 26 Jan 2020. Dr. Ravi Kanan, who left behind his life in Chennai to help cancer patients in the northeast and now runs the Kachar Cancer Hospital in Barak Valley, Assam. Also known as Silchar's savior, Dr. Kanan quit his job in Chennai and shifted to Assam with his family in 2007 to make healthcare accessible in the Barak Valley. Before he transformed healthcare in the valley, it was almost inaccessible for the local community over there. Besides providing free treatment to cancer patients, the hospital also provides accommodation, food, and employment. We are lucky to have him talk to us on challenges in providing affordable healthcare in remote location, technology, cost, and accessibility. We welcome you, sir. Now, may I invite Dr. Prem Nair, Medical Director, Amrita Institute of Medical Sciences, Kochi, and Dr. Yashpal Sharma, President, AHA, to chair the session.
Very good morning to all of you. We will continue our next session this morning. This will be by Padma Shri Dr. Ravi Kanan, Director of the Kachar Cancer Hospital in Assam. Welcome to you, sir. I have as my co-chair Dr. Yashpal Sharma, who is the President of the AHA and who will be co-chairing the session with me. So I will have Dr. Yashpal take over.
Good morning to each one of you. Thank you very much, sir. I, on behalf of AHA and Amrita Institute of Medical Sciences, welcome Dr. Ravi Kanan, Padma Shri. And we are really grateful to you, sir, for being here with us and sharing your experience. I will request you to start today's session. Thank you.
Thank you. Good morning to everybody. I thank Dr. Nair and the organizers of the SASH-2021 for giving me this opportunity to participate in this meeting. I will speak on challenges in providing affordable healthcare in remote locations with reference to cost, accessibility, and technology. When we were talking about this, one of my colleagues, a young colleague, stated that for rural residents to access healthcare, they must have the financial means to pay for services. They must have the means to reach and use these services and the ability to take time off to use such services. They must have confidence in their ability to communicate with the healthcare provider. They must have trust in the service and the belief that they will receive quality care. So I just put it down verbatim as he expressed it. Now, see, there are challenges on the part of the patient and there are challenges on the part of the service provider. I put the fear of hospitals as the first challenge before patients, because now over the period of time, I have come to understand and believe that a lot of our patients, many of them are actually afraid of the healthcare system for fear of diagnosis of a terrible disease or for fear of being impoverished because of out-of-pocket expenses. There is lack of awareness about the options that they have and their rights as citizens of the country. There is a fear of cancer diagnosis. Many of them are working for daily wages. Transport is an issue. There's tremendous faith in local healers, in alternate forms of medicine. Costs of care are an issue. Multiple hospital visits are an issue. Toxicity of treatment as it is perceived is an issue. And there are issues with availability of expertise locally. From the side of the healthcare provider, treatment has to be accessible. It has to be affordable. It has to be of good quality. We must ensure that it is provided in a hassle-free, respectful manner. It has to be equitable. It has to be efficient. It has to be universal. It has to be acceptable. But most importantly, even if we provide all of this, there is nothing to say that the patients will actually accept and access what is given. They may not, you may put up a hospital with everything there, and patients may not come and access it simply because they're afraid of coming there. I would like to talk about all of this in the context of where I work. I work in a town called Silchar, which is in the south of Assam, on the other side of Bangladesh. And like many parts of the country, we have our own issues with travel. There are areas where no vehicular access is possible. You have to walk for miles. Many times there is no way to carry patients, sick patients, to a hospital. So the community will simply fashion a hammock on a bamboo and carry the patient for several miles till they can find access to a motor vehicle. Areas which are, but we also live in a beautiful part of the country, with forests and hills and lot of rain. And Ronald Ross, who won the Nobel Prize in 1902 for his discovery of the malarial parasite, worked in a tea garden hospital, not 25 kilometers from Silchar. His microscope, hand drawings are all there. And it is very inspiring to realize that a man equipped with just his mind, his brain, and some primitive equipment was able to change the course of medical history without access to expensive gadgetry. Poor people cope with out-of-pocket expenses by resorting to distress sales, by borrowing from money lenders at exorbitant rates, and depending on charity from friends, from family, from the care provider. And we have put in place several strategies to address these issues. These are not necessarily in chronological order, and many of them are probably overlapping, but we resort to and these are all continuously ongoing. None of them is implemented and done with. So we resort to proactive, pro-poor branding. We try to fast track all diagnostic workup and treatment. Continuously, we keep looking at cost reduction strategies. And I think technology is the key to leveling the playing ground for those who are in well-off situations and those who are not so well-off. And the most important thing I realize is to build the confidence in the community, in the patient population, to be able to come to the hospital to explain their problems and have the confidence of accepting treatment. And I realize that every activity that we carry out, whether it is for service provision, whether it's for cost reduction, everything is actually a confidence building measure. Now, when I say pro-poor branding, I mean basic clean infrastructure. In the hospital, we have made a conscious effort not to put expensive looking fountains and paintings and marble, because when a common man will go outside an expensive hotel, like Taj, for example, many people will not even enter because they think it is not for them. Same way, if we put up an expensive looking hospital, poor people will be intimidated. And we've tried to create an infrastructure that is not intimidating to poor patients. We constantly engage with our own colleagues to make sure that the way we speak, the way we stand, our body language is supportive. We have offered a whole lot of low or no cost services. We made sure that we don't charge differentially. People who are well off and people who don't have the resources to pay, both pay the same amount of money, both have the same waiting list, both work in the same queues, because if we use the same facility to treat people who are well off and not well off and charge them differentially, then people who are well off will eventually elbow out the people who are not well off. The system that was designed to support poor patients over a period of time without anybody's knowledge, the rich people who pay, will expect better services. They will want the senior most consultant. They will not want a waiting list. They will want special rooms. They will want to be seen immediate. So a system, the healthcare provider also will tend to accept this because the rich man is subsidizing the cost of the poor man. And so the healthcare provider will also justify it. And slowly, the rich man comes, he requires the best doctor, he requires immediate attention, he requires no waiting list. So a system, will slowly become rich focused. And so we have ensured that there will not be any differential charging. We strive to ensure there are no hidden costs. When we discuss with the patient and we say cost of treatment is 10,000, 20,000, 50,000, we make sure we do not charge that. If there are costs over and above it, then the hospital bears it. And we've tried to engage with the community to disseminate this pro-poor hospital ideals in the community so that the community has the confidence to accept it. And then we also put in a whole lot of cost reduction strategies. We fast-track diagnostics and treatment. Frozen section histopathology is a case to point. Conventional pathology takes 2, 3, 4 days for the results to be available. And if we see a patient today, ask him to come for a biopsy the next day, and then ask him to come for a report 4 days later. Sometimes we need to repeat the biopsy. Sometimes we need to resort to IHCs. So we ask them to come a few more days later. People will tend to, daily wage earners will tend to fall through the cracks. And so we've resorted to a strategy of frozen sections. So our whole strategy is patient comes today. The same day he has the blood biochemistry workup. Next day morning, he has the endoscopies, biopsies. Later, he goes for imaging. And when he comes back in the afternoon, the diagnosis is ready, the stage is ready, treatment plan is ready. Within the first 48 hours, we strive to ensure that this happens. So frozen section histopathology helps us enormously. We do a biopsy, half an hour later, the report is ready. I do a mastectomy. By the time the last stitch is put, the diagnosis, a lot of pathology reports that are necessary for further treatment are ready. We have staff who multitask, which reduces the cost of salaries. We have an in-house pharmacy. Pharmacy, everybody knows, has a huge margin. We can buy paclitaxel for 1,000 rupees, and the sale price maybe MRP maybe 10,000, 12,000 rupees. So what we do is we buy drugs at low cost, have a 20% charge for the pharmacist's salary, and give it to patients. We've made sure that we use generics wherever possible, reduces cost of pharmacy. We support boarding and lodging, and we have scrupulously tried to follow evidence-based medicine practices because they help in reducing the costs of unnecessary treatment. With all of this, several years ago, we audited what was happening, and we found that 30% of patients access palliative care, 28% of our patients completed cancer-directed treatment, and almost 60% did not even come for a second visit to the hospital. And then, over the years, we put in a series of measures. Initially, we started creating appointments for everybody, and people who did not report for their appointments, we would call them on the phone and motivate them, support them, offer help, asking them to come back and complete treatment. We also started a process of ad hoc employment provision. Initially, we thought that would be the game changer. We started providing employment to a caregiver because cancer, the treatment takes long and they have to keep coming back for chemotherapy. They have to stay in the hospital or nearby for radiation therapy, and then surgery. And so during the course of treatment of the patient, we started providing ad hoc employment. We started with 30 rupees. Now we pay 300 rupees plus food for a caregiver. And at the end of that, in a year later, we found that 55% of patients completed treatment, which is better than 30%. But the thing is, in a big city like Madras or Mumbai, if 50% of patients finish treatment at Tata Memorial Hospital or Cancer Institute, these are good figures because many patients will come from outstation. They will come for a diagnosis, for an opinion, and then go back to their hometowns to complete treatment. But for me, I'm the last stop. Beyond us, there is nobody else. If they don't have access to treatment in our hospital, 10% will probably go elsewhere, but most of them will simply go home and die. And so we had to do better than 55%. Then we started home care, basically for palliative care. And as part of palliative home care, we also started visiting homes of patients who were not coming back to the hospital for treatment. And, that helped improve the compliance to treatment, pushing it up to 70%. Now, as part of the home care program, when we started visiting homes of people who were not coming back for follow-up, it helped augment the idea that, patients are genuinely in need of support amongst the hospital staff. Then, we started a resource man. We got into a project with the CDAC and we put in place a resource management team. Initially, we were enrolled under the PMNRF team. And then as part of another project, we started satellite clinics. And for a telemedicine project, we put up one satellite center in one of the districts around us, and another telemedicine center in another district. And all the follow-up for these districts started happening from there. All the palliative care work for these districts have started happening from these centers. Initially, the resource management team would also assess the need for support for patients. And we realized that there's a conflict of interest. Somebody has to decide who needs support and then also has to run around for finding the resources. It's a contradictory activity. So we put in place a whole lot of medical social workers who would do the needs assessment apart from other counseling. And the resource management team's job was only to find resources. We also realized, we used to have to charge 100 rupees or 150 rupees every month for any number of visits, any number of consultations. But, cancer patients coming back again and again and again have to end up paying consultation charges every month was a disincentive for many patients. So we quickly put in place a policy of a one-time charge beyond which they did not have to pay for OP consultations, for dental services, for physiotherapy, for several things. We also rigorously started implementing an antibiotic policy, infection control policy, a whole lot of ERAS procedures, again, to improve quality of care and to reduce costs. We engaged with the community very actively for a variety of reasons. One is to instill confidence in the community. Second is to get the community to participate with the hospital in cancer prevention and palliative care activities. We worked with ASHA to create awareness. We worked with ASHA to identify people in need of palliative care. We're also working with several NGOs because, diabetes, hypertension, cardiovascular disease, cancer, strokes, a whole lot of non-communicable diseases are all caused by tobacco, alcohol, dietary issues, lack of exercise, and some infections that are not treated. And so we're trying to create this awareness amongst our champions in the community that if we take care of these 4 or 5 issues, we not only prevent cancer, we also prevent a whole lot of non-communicable diseases, thereby promoting health in the community. The government insurance schemes, the PMJY and our state's Atal Amrit Abhiyan have been boons for patients. They have taken care of a lot of economic needs, that can be addressed without us running from pillar to post. There are loopholes which I'm sure with passage of time will get addressed. And then there are patients, cancer patients, many of them will die. The advantage with cancer death as opposed to an accident death or sometimes a death related to a heart attack is we have time before the patient dies. In a accident or in a heart attack, in a matter of days, the patient is lost, and it gives very little time for the family to become ready for life after the caregiver, after the breadwinner is lost. Whereas in cancer, when patients have advanced disease, we often have several months before the patient eventually passes away. And so we have created, or we are trying to create a process whereby we can identify another family member who can take over the responsibilities of earning for the family. The COVID years have provided us an enormous opportunity for building confidence in the community even more. Fortunately, during the entire episode, when several hospitals had to shut down, we did not shut down for even one day. We were able to put in place a lot of measures to train our staff and keep them safe, to take care of cancer patients and community members who came with COVID, to put up a testing facility to keep the cost of all of this low and not interrupt treatment during their course of treatment. We had an advantage. We were in the Northeast where COVID arrived much after it had come to other parts of the country. And so we were able to learn from what is happening elsewhere. We were able to put in place a lot of measures, and we had plenty of support from the community both in the Northeast and outside. And so that helped us augment our relationship with our patient population more. Technology, I think, is the key to making things better for many of our citizens living in far-flung areas with scant resources. Initially, we used technology to ensure greater accountability and transparency in the organization. All our accounts, finances, everything is on the computer, all our purchases. Anybody can scrutinize what is being purchased in the organization, in the society, in the community, and criticize us or advise us to do better. We have used open source software as much as possible, our own electronic medical records. Simple things, we go on community visits, we see a patient with some skin disease that we don't know what, we are able to take a picture, transmit it to somebody else. Within minutes, we get an opinion from a dermatologist as what it is and what could be done. Very primitive, early form of use of technology. Our whole EMR is written in-house. I have colleagues in the IT section who are simply wizards, and we use open source packs at the moment. We didn't have a radiologist in-house for many years, and we were using teleradiology. I had colleagues in Mumbai, in Chennai, who do all the radiology reporting for us. We're looking at telepathology to augment our pathology services, but we also are working with pediatric oncology groups elsewhere in the country. We don't have a pediatric oncologist, and pediatric oncologist somewhere does rounds in the ward using image information technology tools, using cameras, sees every single patient, looks through the record, gives us, and the doctor sitting in Silchar in the hospital is able to execute what has to be done. We're using technology extensively for human resource training. We have people from all over the world, talking to my colleagues, nurses, technicians, doctors, and we have programs where they are being trained. And then we are also looking at it futuristically to look at centralized. One of my colleagues is working for a PhD on artificial intelligence to predict toxicity during radiation and chemotherapy. We're looking at centralized decision-making, prediction systems, and many other things. Just as a point to illustrate this, we don't have critical care specialists in the hospital. And so we put in place what we call a tele-ICU. We have all these high-definition cameras, which can actually see the monitor on the patient's bedside, which can actually see the patient. This information is transmitted to a group sitting in Bangalore. We have we have physicians, we have nurses, we have people watching patients and the monitors 24/7. Actually, this a patient of ours had a ventricular tachycardia. The cloud physician identified it, instructed the nurse, and as resuscitation was being carried out, the patient arrested. The patient was revived. 5 minutes later, patient arrested a second time, revived again, connected to a ventilator. 5 days later, the patient arrested a third time. Patient was yet again revived. 2 days ago, when I was in the OPD, the lady came she had surgery for a colorectal cancer. She came for follow-up, and I think that is the kind of, so we're now looking at dialysis, renal failure patients. We're looking at cloud technology we don't have access to dialysis machines easily. We don't have access to nephrologists. Many issues are there. And so we're looking at leveraging the advantage of this to start nephrology services. We're looking at creating hospitals around us. Our satellite clinics at the moment are basic, for delivery of palliative care and prevention. And we do a clinic once a month. We're now looking at creating satellite hospitals where surgery can be done, where chemotherapy can be delivered, where palliative care can be done. And I'm actually thinking at some point of time, maybe radiation therapy as well. There are several areas around us which are extremely difficult to access. And I think we need to create hospitals in each of these. There are process challenges that we need to look at. Recruiting and retaining human resources is a major challenge. Maintenance of equipment, simply because we are in a difficult to reach location. Often equipment breaks down, engineer will not come immediately. When he comes, the parts that need to be replaced will not be there. By the time it will be several days or even weeks before the equipment is up and running. And when we have one machine, a radiation machine, for example, and it breaks down, the impact it will have on patient care can very well be imagined. Then cost of equipment, cost of infrastructure, cost of patient care. And then again, coming back, I think building trust with the patients is another very important process challenge. I had the fortune of training under two giants in the country, Dr. Krishnamurti and Dr. Shanta. And Dr. Krishnamurti often used to say, when the patient does not have resources for his treatment, it is the job of the treating physician to find them. And Dr. Shanta used to say, everything for every patient. To be able to do all of this, we have to be friend raisers as well as fundraisers. And it is important for the organization's philosophy to percolate from the director to the doormat. Thank you very much.
Thank you, Dr. Ravi Kanan. That was truly inspirational.
Thank you, sir.
Let me congratulate you and your entire team for taking this up on a war footing and coming all the way from the deep south into the northeast. That must have been quite an achievement. Certainly, your involvement with the lower socioeconomic group and adding technology to it to reduce the cost of care is very remarkable, and it's something that we are all hoping to achieve in the years ahead. So congratulations once again. I'll have Dr. Yashpal take over.
Thank you, sir.
Yeah, thank you, Dr. Ravi. I think it was wonderful talk, and we were really benefited by your talk. Very well explained, the challenges in providing healthcare, especially in the remote areas. And you really elaborated the challenges in a very well manner. I also being from a remote area, would like to share a small example. And I will start with saying that if we have people like you who are committed, things can definitely change. I was in 2010 to 15, I was MD National Health Mission, Jammu and Kashmir. At that time, Ladakh was also part of Jammu and Kashmir. So that time we were really fighting with reducing the infant mortality rate and the maternal mortality rate in the state. At that time it was state. So we suddenly found out, in Leh, Ladakh region, complete Kargil, there is no maternal mortality and the infant mortality for last 2 years. We thought maybe it is because of under-reporting or not reporting. So we planned a visit and visited that place and tried to find out the reasons. Or we thought maybe there are some good practices because of that. It is not there. So accessibility, you said, is the biggest challenge, and how these people overcome the accessibility challenge was Ladakh region. You know that for 6 months it is not connected with any part of the country, including the state within also. So what they were doing that, any pregnant lady from the remote area would find a small space in Ladakh region, in Leh city itself, so that, for the entire period, maybe 4 or 5, 6 months of her pregnancy, she used to remain near the hospital. And all the deliveries were being conducted at the institution itself. So that was the reason, that was one reason why, there was no maternal death and infant death. Another reason I found that people were very dedicated. Doctors and nurses. Doctors were constantly training the nurses and the paramedical staff in different, things. And the pediatrician, although there were very limited number of pediatricians there, they were also too committed that, they didn't allow even single death to happen. I would like to give example of Asha. You told Asha. You see, there, we came to know that Asha was just being paid peanuts, because for if she started from one place with the patient to the hospital, it would take at least 7 to 14 days for her to go back to her home. But that stay, etc., was not covered. So based on the inputs we got from these two places, we had many other remote areas in the state. So we innovated certain things and implemented for the betterment of the patient. And believe me, based on those experiences and innovations, now we are one of the best as far as infant mortality and maternal mortality is concerned. I will not take much time of yours, and I really compliment you for your good work you have done. We can see how you have been to the inaccessible areas and how you have been helping the poor patients, and kind of understanding you have how to give care, especially the medical care to the cancer patients in the remote areas is remarkable. Thank you very much, Dr. Ravi. I'll open the house to the questions.
Thank you, sir. India is really a continent, and what we do in one area may not be applicable identically to another area. So there's a lot of cross learning that is possible. And as you mentioned, the ASHA have the math in favor of them. Each ASHA is responsible for 1,000 population, and they're all enthusiastic, willing people, and if properly incentivized, they can be used to change a lot of things in the community. Thank you, sir.
Dr. Vijay Kumar.
Yeah, Ravi, good morning.
Hi.
It's just for a comment for the benefit of all the students here, especially, Ravi is somebody who has walked the talk, actually, who's actually done it, and I would encourage a lot of people to actually go and visit the place, understanding the problems of what are the actual problems and how do you solve them, because every place has its own problems, and looking at, the number of people to get a qualified medical oncologist or get a radiation oncologist, even a qualified physician was so difficult. I remember when he started off, the area is inaccessible, but to overcome those challenges, how we use there's a lot of goodness in the community. How do you use your community people to, build up a workforce in the healthcare industry? We build up physician assistants, who can really do almost the entire job of a physician. And how do you overcome all these challenges? People don't come because, they are daily age workers and they cannot afford to lose one day. How do you just overcome it? Just by doing a frozen section of all specimens. I mean, it's unimaginable in a hospital like this. If you had to do a frozen section for all the specimens that you do, all the surgeries that you do every day, but it gives you a result immediately within a few hours. And these are sort of practices which, you must learn to see how to adapt it in different conditions. And somebody who has actually done it, for which he's even got the Padma Shri, and it's wonderful. The work is. I remember once, I've gone to Silchar many times, but once when I went, the plane kept flying for 9 hours overhead, and I couldn't land because of the weather was not permitting. So the terrains are so difficult, and still going and getting all these things done, and leaving a comfortable job in Chennai and going to such an area and doing things is something which is, an eye opener for a lot of us. That's why I just wanted to put in a word.
Thank you, Vijay.
I must compliment you for your commendable job that you are doing. Since you are talking about affordable healthcare, I would like to know that I am Dr. Paramhans Mishra, CEO, IQCT Medical College Hospital, Durgapur, West Bengal. We are finding it a great difficulty to generate resources because government has launched a scheme, Swasthya Sati, in West Bengal, where they pay just 3,000 rupees for ICU care, inclusive of medicine, investigations, treatment, consultation, everything, and 1,500 rupees for ward patient. Now, we get 80% of patients from Swasthya Sati. We hardly get 10% patient for cash. We are finding a great difficulty in generating resources, and being a medical college, we are supposed to have a fixed number of faculties, doctors, nurses, plus running the hospital also. And we are really finding it difficult to pay to the vendors because cost of the materials have gone high. So can you suggest some way how we can come out of this difficulty?
Thank you. So I may not have a solution for your question, but what we do is, the one thing that we've taken a decision is all equipment will be purchased as a gift. We have not purchased a single equipment on our own. And so we don't have to worry about return on investment. If I buy a Linac 10 crores, part of the hospital's expenditure is repaying the loan. And because I take a decision that everything will be supported, I don't bother about return on investment. As far as consumables go, we bargain with everybody, shamelessly. Somebody gives for 5 rupees, you give for 450. Somebody gives for 4. Only thing we make sure is that the think product is genuine, they have the required certification, they have the required backup. We don't go for innovative molecules at all. Everything is generic unless there is no other option. And very often we will not go into second line, third line, fourth line chemotherapy where we know that the outcomes are poor. Patient fails first line except for very specific situations, where we know second line, third lines may help. But we don't go and spend money on situations where the second line salvage chemotherapy, palliative chemotherapy has very marginal benefit. We rely on aggressive best supportive care and palliative care. And so we try and reduce unnecessary costs wherever possible. Now, in a situation like lung cancer, where everybody talks of molecular basis and how it is changing the whole story, we have to wait to see what will eventually happen. I'm still not totally convinced that lung cancer can be changed by genetics and targeted therapy, but I guess it will happen over a period of time. And when that happens, we have to be able to gear up to do all that. I don't have an answer now. Maybe sometime later I will be able to answer that question.
I would like to add here that, I'm really very happy to hear from you about the pro-poor branding. I mean, it's a new concept for me also. We were actually thinking about it, but the right appropriate terminology you gave today. Why I'm saying so is actually I'm looking after as medical director new medical colleges. So government of India has sanctioned medical colleges in the remote districts. Now what the R&B people are doing, they are making new medical colleges in the remote districts, and they are asking for extra money. They say when we built a hospital in the remote area, the cost of construction is quite high. But I always keep on telling them why you are putting up granite and tiles to the extent that even the poor patients don't feel like coming inside. It just looks like a mall. So providing technology or the material, locally available material, I think that can be one of the things which can reduce the cost also and make the patients more comfortable in the settings. So there are many ways of reducing the costs, like Dr. Parmahans was asking. Yes, one of the way you told that, you do a lot of bargaining. And we can use technologies to the extent that these are required in the different settings. I mean, we don't have specialists, but we get all the gadgets. We keep, because it's an ICU, there's nobody to operate, but we get all the gadgets extra, with the extra cost. So that increases the cost and the burden on the patient.
Yes, sir. And library is another opportunity. Now everything is online. And as part of the National Cancer Grant, we have access to the NCG library. So we don't have to spend money on journals and books and all that. It's a huge cost saving. It does not deprive us of recent advances in knowledge and things like that. So I think technology can make a huge difference.
Yes.
Good morning, Dr. Kanan.
Good morning.
I'm Dr. Archana Mishra. My question is somewhere based on my personal experience in 2017. We had a RFP proposal on a PPE model from government of Jharkhand. So we submitted our proposal where they wanted 100% funding from the private. So our research, everything what project we made, it was based on the break-even model somewhere not less than 7 years. The biggest challenge what we were coming across is mobilizing the human resource. Other than what Dr. Yaspal Sharma has mentioned and Dr. Paramhans Mishra sir mentioned, we had worked out on something like GNRC model, which is in your Assam. Guwahati Nursing Neurological Research Center. We were working on all ecosystem in such a way that we compromised on all the resources. But what was the biggest challenge we came across is the human resource. Mobilizing the human resource in city like Jharkhand, I mean Ranchi as a capital, which was the Medicity which they have proposed was somewhere 200 kilometers away. So that was the reason why we had to withdraw our proposal. So I request if you can help us out so that we can have certain
human resources is always a challenge. It will probably be the biggest challenge. We can find money for equipment, we can find money for drugs, but having and unless you have a happy flock of human resources, you cannot make others happy. And keeping your task, the workforce happy is a full-time job in itself. And one of the things that we often do is task shifting, where a doctor has to do screening, a trained nurse can do the screening. Where a doctor has to do a CT guided biopsy, we've done almost 500, 600 lung biopsies by using trained technologists, and you won't believe we did not even have 5 complications. And the material yield was very good. And so we can resort to task shifting. The other thing is, there's a lot of emphasis on surgical oncologists, medical oncologists, radiation oncologists. You need a radiation oncologist, otherwise AERB will not give you approval. But a trained surgeon who's trained to do a good mastectomy or a good gastric resection or a good APR does not have to have an MCH in surgical oncology. The decision making for operating or for giving chemoradiation can be done through a tumor board. And tumor boards now, NCG has shown very easily, we can always do it online. We can have several institutions, several experts participating, and every patient can be put through a tumor board. Same way, medical oncologists are a very difficult breed to get, I don't mean any offense, but they are difficult. And so we can train physicians, whether I know there will be some difference, but when you don't have an option, to use physicians, train them for medical oncology. And so again, if you go work through a tumor board, the medical oncologist who's a trained physician and the surgical oncologist who's a trained surgeon, we should be able to deliver similar quality of care. And surgeons and physicians are a lot more plenty. Even for our own area, we are looking at something like this. We don't have a pediatric oncologist. So we're working with a pediatric oncologist working in Bangalore. She does rounds, she does patients. And we work with the Indian Pediatric Oncology Group in Delhi. Every Saturday we have a tumor board. So again, using technology can help us greatly to reinforce whatever resource we have. There are people, as Vijay said, plenty of goodwill across. We only have to ask. And so I think this should be possible.
In-house group, if not, we will go to the online participants. Any online participants? Questions? Once again, Dr. Ravi, thank you very, very much. It's
thank you, sir.
Very inspirational and for all of us, and a lot of thought needs to go into this. I think you've done a fantastic job. You'll have a lot of visitors coming to you.
Thank you, sir. Thank you very much.
Yeah, thank you very much. Please keep in touch.
Thank you, sir. I will.
We are extremely grateful to you, sir, for sharing your experiences with us. On behalf of SASH 2021, we are happy to present a memento as a token of our gratitude to our speaker, Padma Shri Dr. Ravi Kanan.
Thank you. Thank you very much.
Now, may I invite Professor Dr. D.K. Vijay Kumar to present the memento to our chairs, Dr. Prem Nair and Dr. Yashpal Sharma.